Hello friends, welcome to Kavita Medicos Education. This is part second of inflammatory bowel disease condition. So here in part second, we are going to start with the clinical manifestation, that is sign and symptoms of IBD. Okay, so here I have written the sign and symptoms in different way. Okay, here we will study about the ulcerative colitis clinical manifestation, and then we will go for Crohn's disease sign and symptoms. Okay, so let's start with the ulcerative colitis sign and symptoms. So first symptom we have, that is diarrhea. Okay, so in ulcerative colitis of part first of this video, we have studied about that ulcerative colitis is a disease condition of large intestine. Okay, so mostly in ulcerative colitis our large intestine is highly affected. Okay, it have ulcer, inflammation, irritation. Okay, so what are the sign and symptoms that we will see in ulcerative colitis patient? So first symptom we have diarrhea. Diarrhea means loose watery stool. Okay, here patient will have a chronic diarrhea, he will have a recurrent diarrhea. Okay, the diarrhea frequency will be increased. Okay, so patient have loose motion, that is in a chronic form. He will have a recurrent diarrhea formation, and next most important thing, that is bloody diarrhea. So mostly in ulcerative colitis, patient pass the blood in stool. Okay, why? Because mostly the ulcerative colitis affects our rectum area first. Okay, this disease will affect our rectum area first. Okay, so the blood which will come in the stool, that will be in a bright red color. Okay, so here in ulcerative colitis, patient will pass the blood into his stool. Okay, this is the first symptom. Next we have steatorrhea. So what is steatorrhea? So it's a condition when the patient passes the fat in the stool. Okay, that fat stool is known as steatorrhea. Okay, why patient is having a steatorrhea condition? Because due to the inflammation, irritation, this inflammation will irritate our goblet cell. Okay, this inflammation will do a effect into our goblet cell. Okay, so these goblet cells are present into the mucosa layer of our intestine. So we have 4 layers in our GI tract. Okay, so these goblet cells are present in our mucosa layer. Okay, when our intestine will get swell, it get inflamed, then what will happen? The goblet cell will become hyperactive. Okay, and this goblet cell will produce lot of mucus, and this mucus will come out through the stool. Okay, this fatty stool is known as steatorrhea condition. Next we have tenesmus. So what is tenesmus? Tenesmus is a feeling of constant urge to pass stool. Okay, patient will feel that he have to pass the stool urgently. Okay, that is the feeling is known as tenesmus. Okay, because this tenesmus occur due to the hyperinflammation of the rectum area. Okay, when this rectum will become inflamed or irritated, then the muscles in the rectum will get weak. Okay, and the anal sphincter muscles will lose their control. Okay, that's why patient will have a feeling of tenesmus, that is incontinence or constant urge to pass the stool. Next we have abdominal pain and cramping. Here a patient will have a abdominal pain, and that pain will be in a cloaky form or in a cramping form. Okay, and here patient will have a left sided pain because our rectum and colon area is at the position of the left side. Okay, so this patient will develop the left side abdominal pain. Okay, next we have fecal urgency and incontinence. Here patient have a deep fecal urgency feeling. Okay, and sometimes patient can pass the stool in that moment also. Okay, that is known as incontinence feeling, means the patient is not able to hold the stool for longer period of time. That is known as incontinence phase. Next we have fever, fatigue and weakness. Here patient develops all the symptoms of the disease condition. Okay, patient will have a malaise feeling, he will have a weakness in his body, he will have a fatigue condition, and here the patient will develop the fever also. Why patient is getting fever? Because when our immune cell will attack to our large intestine area, then this immune cell will also go to our systemic circulation. Okay, and from the systemic circulation it will move towards our brain. Okay, and from there it will stimulate our hypothalamus. Okay, and hypothalamus will rise the body temperature, and this leads to the fever condition in the patient. Next we have weight loss and loss of appetite. So here patient have a nausea feeling, he will have a vomiting feeling. He will not eat anything due to the deficiency of vitamins and minerals in his diet. He will have a weight loss condition. Okay, and this frequent diarrhea will also go for weight loss. Next we have anemia. Okay, patient is having a bloody diarrhea. Okay, that's why he will have an anemia condition in his body. Next we have dehydration and electrolyte imbalance. Okay, due to the malabsorption of water and electrolytes from the large intestine. The large intestine is in a bulky form. Okay, it is in a swelling form, it have an inflammation, so it will not able to absorb the water properly, and due to which patient will have a dehydration in his body, he will have an electrolyte imbalance. Now there are some other extra manifestations, symptoms which I have written here. Okay, as we all know that our immune system is attacking to our large intestine, but in the same way this immune cells are also going into our blood. Okay, so due to the systemic circulation, this immune cell will also attack to our other organs into our body. First we will have, patient can have arthritis. Okay, it's a condition where there is a tenderness, inflammation and pain in the joints of patient. That condition is known as arthritis. Okay, next we have skin lesions. Skin lesion means he will have a skin problems, like we have erythema nodosum and pyoderma gangrenosum. So patient can develop a bumpy red nodules in his skin, or he can have ulcer or gangrenosum in the sheen of leg or in the front of the leg. Next we have eye problem. Okay, so due to the involvement of immune cell, our immune cell will also attack to our eye epithelial layer, and due to which patient will develop several eye problems like conjunctivitis, he will have uveitis, and he will have episcleritis condition. Next we have primary sclerosing cholangitis. So what is primary sclerosing cholangitis? It means the immune cells are also attacking to our bile duct. Okay, so what is the role of bile duct? So role of bile duct is to carry the bile. Okay, and the role of bile is to digest the fat, but what is happening here, our own immunity is attacking to our bile duct. Okay, due to which the bile duct will get blocked. Okay, there will be fibrosis, there will be scar formation into our bile duct, and this bile will move backward to the liver. Okay, then this bile will damage to the liver. Next we have toxic megacolon. Toxic megacolon means when the large intestine will become dilated. That condition is known as toxic megacolon. Okay, it's a complication, it's a main complication of ulcerative colitis. Here the large intestine will get dilated. Okay, if this large intestine will get dilated more than 6 centimeter, then there are chances that colon may be rupture. Okay, patient have a rupture in his intestine area, and it's a urgent or emergency. Okay, it's a emergency condition. Now let's discuss with the Crohn's disease. So in part first of my video, we have studied about the Crohn's, that it's an inflammatory disease condition which will affect from mouth up to the anus region. Okay, so here in Crohn's, patient will have diarrhea condition, but in his diarrhea the patient will not have blood. Okay, he will have only watery diarrhea. Okay, there will be non-bloody diarrhea. Next we have abdominal pain, similarly as we have studied about ulcerative colitis. Okay, so here patient will develop abdominal pain, and that pain will be in a crampy and in a colicky form of pain. Okay, and this pain will develop in the right lower quadrant area of the patient, because this terminal ileum have a position at the right ileum area. Okay, so patient have pain, and that pain will happen mostly at the right lower quadrant area. Nextly, he will have a fatigue condition due to the loss of energy from his body, and due to the chronic inflammation of disease condition, he will have a malaise and fatigue condition, and here patient will also have a weight loss condition. Next we have steatorrhea. Steatorrhea is condition when the fat will go into the stool. Okay, the fat rich stool is very bulky, it is in a greasy form and it's in a foul smelling form. Next he will have a fever condition, okay, in which the body temperature will rise. Next he will have anemia. Just remember one thing, that in Crohn's, patient will have anemia, and that anemia is due to the vitamin B12 deficiency, because Terminum ileum is the region, okay, is a part of our body which absorb the vitamin B12. But here, due to the disease condition, terminal ileum will not absorb or do the formation of vitamin B12. So patient will develop the vitamin B12 deficiency. Here he will have anemia. Next we have perianal disease condition. So here patient will develop the disease or lesions in the anal region. Okay, so what are those disease or anal fissure? Okay, so patient can develop pain in the anal region. He can have a fissure. Fissure means a crack in the anal region. Why is having a crack in the anal region? Because this ulcer is penetrating, or this ulcer is very deep. Okay, if this ulcer is very deep and it will penetrate to all the layers of our skin, then it will form the crack in the anal region. Next we have fistula condition. What is fistula? When one of the organ of the body will attach to the other organ, that condition is known as fistula. Okay, so he will have fistula and he will have abscess condition. Abscess means the pus collection in any area of our body, that is known as abscess. Okay, next we have fistula. So how many types of fistula can patient have? Okay, he can have enteroenteric fistula when the one area of small intestine is attached with the small intestine only. Okay, that is known as enteroenteric. Next we have enterovesical, when the part of small intestine is attached with the urinary bladder. Okay, bladder, that is known as enterovesical. And next we have enterovaginal. Okay, that is when intestine area is attached with the vagina. Okay, that is known as enterovagina. So there are many kinds of fistula. Okay, next let's study about the extraintestinal manifestation. Okay, what are the other symptoms that we can also notice in the patient? First we have aphthous ulcer. What is aphthous ulcer? These are the ulcer which develop in the mouth of patient, that is known as aphthous ulcer. Okay, these are oral ulcer. Due to the vitamin deficiency and nutrition deficiency, patient will have aphthous ulcer, and our immunity is attacking to our mouth epithelial layer. That's why patient is getting aphthous ulcer or oral ulcer here. Next we have arthritis. It's an inflammation of our joints area, that is known as arthritis. Same which we have read in the ulcerative colitis. Here patient will also develop the skin lesions condition like erythema nodosum and pyoderma gangrenosum. Next we have eye involvement. Eye is also involved here, and the disease which you can see in the eye, that is known as uveitis and episcleritis. Next we have kidney stone formation. Here there is a cholelithiasis condition. Okay, when the stone get formed into the kidney, that condition is known as cholelithiasis. Okay, why this condition is occurring into the body? Okay, as fat is not fully absorbed. Okay, fat getting malabsorbed into our small intestine. Okay, if fat is not fully absorbed, then this fat molecule will bind with the calcium. Okay, and this oxalate ions will get free into our body. Okay, and this oxalate ion will go into the kidney, and then in the urine these oxalate ion will bind to the calcium and they will form calcium oxalate stone in the kidney. Next we have kidney failure. Due to the stone formation, patient can also suffer from kidney failure. Next we have malabsorption of fat soluble vitamins. As fat is not fully absorbed into our small intestine, so here the patient will have a lack of vitamins, like we have vitamin A, D, E and K. Okay, so he will have a malabsorption of fat soluble vitamins. So these were the signs and symptoms of so next we have diagnostic evaluation of inflammatory bowel disease. Okay, so how we will diagnose the inflammatory disease condition? So first we do history collection and physical examination. Okay, this will give us the clue for the disease condition. So in history collection, we will collect all the past as well as the present history of the patient, in which we can ask the patient several questions like, is patient have any blood or mucus present in his stool? Does he have any fatigue condition? Does he have any fever condition or abdominal pain? Okay. Next, you can ask the patient about the family history, because IBD is a genetic disease condition. Okay, so you can ask the several questions that anyone in his family is suffering from ulcerative colitis or Crohn's disease, or anyone is having a cancer. Okay, so here we will collect all the past and the present history of the patient. Next, we will do the physical examination. This is a head to toe examination of the patient. Okay, so here we can check the appearance of the patient, how patient is looking. Okay, is any pallor sign is in the patient or not. Okay, this pallor sign will indicate the anemia condition of the patient. Next, you can ask the patient about the sign and symptoms, like does he have any fever condition, does patient have any weight loss condition. Okay, and next we can also check the abdomen area of the patient. Okay, so in the abdomen area we can check for the distension of abdomen, or is there any tenderness is present or not. And next we can check the mass in the right side of the abdomen. Okay, so right quadrant mass will indicate the Crohn's disease condition. Okay, and next you can also check for the extra manifestation or extra clinical symptoms, like is patient have any joint pain, is he have any eye problem or skin problem, or does patient have any mouth ulcer. Okay, so here we are checking the sign and symptoms of the patient. Okay, next we will go for blood test. So in blood test we will do the CBC, that is complete blood count. Okay, so this blood test will give the clue for the disease condition. Okay, it is not the confirmatory test for this diagnosis. Okay, it will only give the clue for any disease condition. First, in blood test we will do CBC, that is complete blood count. So if there is low HB level or if there is low iron level, it will indicate the anemia in the patient. Okay, it will suggest that patient is having a chronic blood loss condition, which is mainly happens in the ulcerative colitis. Okay, due to the bloody diarrhea. So low HB and low iron will indicate the chronic infection or chronic blood loss in the patient of ulcerative colitis. Next, we have high WBC. So what is the medical term for the high WBC? That is known as leukocytosis. Okay, high WBC means leukocytosis. Leukocytosis is a medical term for high WBC. So high WBC will indicate the active infection and active inflammation in the patient body. Next, we have high platelets. So what is the medical term for high platelets? That is known as thrombocytosis. So high thrombocytosis or high platelets will indicate the chronic infection or chronic inflammation in the patient. Okay, so it will give the clue for the IBD. Okay, it is not a confirmatory test. Next, we have endoscopy. So endoscopy is a gold standard test for the inflammatory bowel disease condition. If endoscopy is done with the biopsy, then it is known as a confirmatory test for the IBD. Okay, so what is endoscopy? So in endoscopy, a flexible guide wire is inserted into the GI tract of patient. Okay, and in that guide wire, a camera is attached. Okay, so through the camera we will see the inner lining of our bowel. Okay, that is any redness, swelling, ulcer or lesion formation is present or not. Okay, so endoscopy can be done in three forms. First, we have colonoscopy. Okay, so this colonoscopy is basically done in the patient of ulcerative colitis. Okay, so in this colonoscopy we are checking the large intestine with the terminal ileum. Okay, so this colonoscope is inserted from the rectum area or from the anus area of the patient, and it is inserted up to the terminal ileum. Okay, it will help us in differentiation between the ulcerative colitis and the Crohn's disease. Okay, next we have sigmoidoscopy. So in sigmoidoscopy we are checking only the rectum and the sigmoid colon area of the patient. Okay, so these both tests are done in the ulcerative colitis patient. Next, we have upper GI endoscopy. This is basically done in the Crohn's disease condition. Okay, because Crohn's disease condition occur from mouth up to the anus area. Okay, it can occur anywhere. So here we are doing upper GI endoscopy basically in the Crohn's patient. So it is done from mouth up to the anus. So endoscopy will help us in watching the inner lining of our gut area. So okay, it will show the redness, it will show the lesion formation, it will show the ulcer in our GI tract. Okay, so here we are checking only the inner lining of our intestine or inner lining of our GI tract. Next, while we are doing colonoscopy, then we will take a tissue sample from the infected area or from the infected bowel. Okay, so while we are performing the colonoscopy in the patient, we will do the biopsy with the colonoscopy. So in biopsy, we are taking a small tissue sample and we are checking that tissue sample under the microscope. Okay, so this biopsy is a confirmatory diagnostic test for the IBD. Okay, so when endoscopy is done with the biopsy, then it's a confirmatory diagnostic test for the inflammatory bowel disease condition. Next, we have imaging study. So why we are doing imaging studies as we have done endoscopy? Because in endoscopy, we are checking only the inner lining of our gut system. But in imaging studies, we will see our gut area in 3D form. Okay, we will see our gut area in a complete form. That's why we are doing imaging study. So there are various kind of imaging, like we can also do the ultrasound abdomen. We can also go for X-ray of the patient. Next, we have CT angiography. Okay, so here we are taking lots and lots of images of the patient, and then we will make a small video clip from those images. That is known as CT angiography. So angiography is a type of test in which a contrast dye is injected to the patient, or we can give contrast dye, that is known as barium, from the mouth of patient. Okay, and this contrast dye will line up our all GI tract. Okay, and then we will take several images, that is known as CT angiography, because we are taking a dye here. Okay, next we have MRI. MRI is basically done in the patient who are very young, because MRI is very safe than the CT scan. In MRI, there is a less radiation. Okay, so we can also do CT or MRI angiography. Next, we have stool test. Why stool test? Because in ulcerative colitis, patient have blood and mucus present in his stool. That's why we are doing stool test. So in stool test, we can do any type of test. First, we have stool routine examination. Here we are only checking the appearance of the stool. What is the consistency of a stool? Okay, how is any blood or mucus is coming or not? That is known as routine examination. Next, we will do stool culture. This culture is done under the microscope. Okay, so in this culture, we are checking the parasites. We are checking for the microorganisms which are present in the stool, like is any viruses, fungus or bacteria are present or not. And we can also check the RBC cells here. We can also check the pus cell or any blood cell are present in the stool under the microscope. Next, we have stool calprotectin. So what is calprotectin? So calprotectin is a substance which is released by the neutrophils. Okay, whenever we have an infection or inflammation into our large intestine or into our bowel area, then our neutrophil, which are our WBC cells, okay, then our neutrophils will release a substance that is known as calprotectin, and this calprotectin will come with the stool. Okay, so here we are checking the presence of calprotectin in the stool. Next, we have inflammatory markers. This inflammatory markers is again done by the blood test. Okay, so suppose if patient have increased rate of ESR. So what is ESR? ESR means erythrocyte sedimentation rate, means how fast our RBC gets settled down. That is known as erythrocyte sedimentation rate. Okay, what is the fastest rate of RBC settling down? Okay, so if patient have increased ESR, it means he is suffering from any infection or inflammation. Next, in blood test, we can check for CRP, that is C-reactive protein. This protein get high whenever we have infection or inflammation. This protein get high and this is released by our liver. Okay, so here we are checking the C-reactive protein. Next, in blood test, we can also check for the nutritional deficiencies. Okay, if patient have low protein, that is known as low albumin in his blood, which will indicate the malnutrition condition of the patient. Okay, next we have low iron and low ferrin and low ferritin condition, and next we have vitamin B12 deficiency. This vitamin B12 deficiency will occur in the Crohn's patient, because in Crohn's patient, the terminal ileum will not able to absorb the vitamin B12 properly. So he will have a vitamin B12 deficiency. So here we are checking the malnutrition or nutrition deficiencies in the blood of patient. Next, we can go for serological test. So in serology, we have two tests. First, we have ASCA, that is known as anti-Saccharomyces cerevisiae antibody. These are the antibodies which are manufactured or which are made by our immune cell. Okay, so these antibodies are released in the presence of a yeast, and the name of yeast is known as Saccharomyces cerevisiae. Okay, so our immune cell will release some antibodies in the presence of a yeast that is known as Saccharomyces cerevisiae. So if these antibodies are high in our blood, it will indicate the Crohn's disease. Okay, so basically ASCA is done in the ASCA. If there is more ASCA in the blood, it will indicate the Crohn's disease in the patient. And for ulcerative colitis, we do PANCA, that is known as perinuclear anti-neutrophil cytoplasmic antibody. These are the antibodies which are released by our immune cell. Whenever our immune cell get hyperactive, then they will release a antibody that is known as perinuclear anti-neutrophil cytoplasmic antibody. Okay, so this will indicate the presence of ulcerative colitis in the patient. So these were some diagnostic tool for the IBD.